extensive lymphatic cystic malformation.
Thank you, Paloma. Indeed, I present today our experience with maternal serolomus therapy, or MST, for the treatment of extensive fetal lymphatic cystic malformation in a series of 6 cases from our reference center for superficial vascular anomalies, dedicated also to fetal medicine, imaging, and therapy. As you know, extensive fetal lymphatic malformation can be life-threatening conditions due to their cervicofacial location, thoracic or abdominal. They can be at high risk of airway compromise or massive tissue infiltration at birth. Sirolimus has shown proven efficacy in postnatal low-flow vascular anomalies, with the principle that the earlier the treatment, the better the response. MST is based on the fact that sirolimus crosses the placenta approximately 30% of the maternal dose, which is the fetus, according to Emmanuel Serron, we published in the first cases in 2023. This presentation reports our own experience in an 18-month series. Over the study period, 15 fetuses were referring to our center. 5 were excluded because of ultimate diagnosis of teratomas, as shown on careful expertise of fetal imaging, showing tumoral cystic lesion with some vegetation within the cyst component. In our experience, this data represents an important warning in selecting cases for MST. 4 others were excluded to do small malformation suitable for postnatal sclerotherapy. 1 had parental refusal and termination of pregnancy, and 1 had fetal death before treatment. This left 6 fetuses treated with MST. Our protocol starts at 3 milligrams per day, titrated weekly to target the maternal residual blood levels above 12 nanograms, corresponding to an extrapolated target fetal levels of 4 based on the 30% transfer rate. The maximum dose of MST was 14 milligrams per day, continue until delivery. Looking at our results, we use a 0 to 4 response scales, where 4 means almost complete regression. Case 1 and 2 achieve a partial response, score 2. Case 3 and 4 achieve almost complete regression, score 4, as you can see in these cases involving the right hemithorax, involving also the arm, and with complete regression at the level of the thorax at birth. Case 3 and 5, sorry, case 3 and 4, case 5 show a marked improvement, score 3, and case 6 unfortunately show no response, score 0. Overall, 5 or 6 treated fetuses show partial to almost complete regression. Mean gestational age at delivery was 38 weeks, with a mean birth weight of 2,877 grams, which is reassuring data. Side effects were limited to mild mucositis in 2 patients and hyperglycemia in 1. No major obstetric or neonatal complication were observed, and important data, transplacental transfer was highly variable, equivalent between cord and maternal blood in 2 patients, higher in the cord in 2, and higher in the maternal blood in 1. This confirms that the 30% transfer factor is not universal. Let's describe our 5 cases in details. At 28 weeks, this fetus present with extensive abdominopelvic lymphatic malformation involving also the anterior peritoneal cavity and right abdominal wall. Intestinal loop were no longer identified on MR. MST was started at 30 weeks at 6 milligrams, titrated to up to 14 milligrams. At delivery, at term, there is a major reduction in intraperitoneal cyst, grade 3 response, and cord and maternal level were similar. However, the postnatal examination revealed findings were missed prenatally, a large capillary malformation, macrodactyly, and sandal gap, confirming the diagnosis of PROS. This is also an important warning. Prenatal imaging cannot exclude PROS, which is an important issue regarding prenatal counseling. So, in conclusions, MST is feasible and well tolerated. 5 of the 6 fetuses show meaningful regression. Early treatment gives better results with optimal windows between 26 and 28 weeks gestation. Transplacental serum transfer is highly variable between 20 and 100%, and the 30% rate should not be taken as universal. Dedicated pharmacokinetic studies are urgently needed. And finally, and I cannot stress this enough, MST should remain within expert multidisciplinary referral center for carefully selected cases. And I would like to conclude by drawing your attention to a closely related finding. The same therapeutic approach, MST, can also be used in the context of Casabar-Merit phenomenon, complicated fetal caposiform hemangioma, as shown in our dedicated poster that you can see today. Thank you so much for your attention.
I just feel the urge to say thank you, Ron. His presentation is critically relevant. I hope with this I will be able to convince my colleague at my institution. It's pretty difficult, you know. So thank you so much.
Thank you.
I want to echo that. Thank you so much for sharing that experience. Joyce came from Stanford University. I have 3 short questions. Number 1, when you titrate your maternal dose to 14 milligrams daily, what kind of a trough level do you get? First question. And second question is that the mode of delivery for these babies, are they, did they need special procedures? Were there C-section? Were there perinatal complication? And the third question is that, so after the baby is delivered, did you check the blood sirolimus level?
So for the mode of delivery, there is 3 C-section and 3 vaginal delivery, and no obstetrical complication. That was the main issue, because in the case of Emmanuel, they were afraid to have complication with C-section delivery, and we discussed with surgeons, abdominal surgeons, dedicated to hepatic transplant, and they told us you can continue till delivery. You do not have any complication, and we did not have any complication at term. And because in the case of Emmanuel, they begin at 22. For some of our cases, we begin in the 3rd trimester, and it was urgent to get a very high residual blood levels and to continue to have the maximum impregnatation for the fetus with sirolimus. So we prefer not to stop sirolimus before. And so we do have concentration of sirolimus in the blood, in the cord, and for the mother. But in fact, there is differences in the timing of the last maternal dose at delivery. Some samples were not at the same time. So when you have a C-section, you can schedule the C-section with vaginal delivery. We cannot do this kind of strategy and have something which is really relevant to compare. So what is interesting is that in 2 cases, the fetus has higher dose than the mother. So regarding the blood levels for the fetus, or it was for the fetus or for the mother? You asked me.
Both. When you're at 14 milligrams daily given to
Yes,
the mother,
we get result at 14. So when we were at more than 12, when we get 12, we say it's good, we can keep the maternal dose. But our goal was to have at least 14 as the residual maternal level.
Thank you.
Thank you, Laurent. It was a great presentation. What about the evolution of the babies with near complete regression delivery? Did you systematically restart sirolimus or did you wait?
Regarding the type of malformation, there was all mixed or mainly microcystic. One is purely macrocystic. This one, we stopped at delivery. There is no sirolimus after delivery, and now he is 2 years old, and there is no recurrence at all. For all the other, they are still on sirolimus or alpelisib. 2 of them, because of infection under sirolimus, we switched to alpelisib, but all are still on either sirolimus or alpelisib. And the one that I show you with a good response is in fact under alpelisib now, and the thorax is correct. There is still some infiltration of his right arm.
Thank you.
Thank you for this important work, Alyssa Engel from Cincinnati. For the women that underwent C-section, you said you didn't hold the sirolimus prior to C-section. Did you have any issues with wound healing in that population?
No issues.
Thank you. Sweta Marco from Cincinnati Children's. Couple of questions. I know you were targeting a specific level in the mom, but did you see any tendency in maybe the patients that had higher levels, more regression? And the second question is, did you have any airway involvement in the kids? Because those are kind of the more complicated ones, I feel like.
We don't have any correlation between the level with the mother and with the response. In fact, it's difficult to understand why there is differences like this in the transfer of sirolimus in the placenta. We know that may be some differences in the expression of the glycoprotein in the placenta, which is important for the transfer of the sirolimus within the placenta. And it's why we are now doing some pharmacokinetic study with artificial placenta to improve, in fact, the dose, the maternal dose. For sure, there is placenta maturation also. And what is interesting with the case of Emmanuel, Emmanuel says that it's 30% rate. But they did 3 chronosynthesis. And the first one, the rate was below 30. And the last one that we did in the 3rd trimester, it was in fact above 30. So you did a mean of the 3 chronosynthesis level. But when you will look at your article, we see that the level is increasing at the end of the pregnancy. So it's why I think that 30% rate is not an inversion.
Any airway?
Sorry.
Airway involvement?
We had airway involvement in the last case with no response at all. He was born in Toulouse. We switched to alpelisib. All have a Pic-Tressier mutation found on biopsy, except for the one with complete regression. We did not biopsy, and this one has serious airway complication. And at the end, I went to Toulouse to put bleomycin around the larynx and the interlocution. And at the end, it improved, but it was a very severe case. Yes, but we were expecting a good result with this one because it was a more severe patient, and unfortunately, no response at all. but no explanation. There is no, we look for another mutation. It was a hotspot, so no explanation for this one.
Last question.
Milena Bezakova, Santana Children's Hospital, Vienna. I wanted to ask about the last patient which was not responding, if there were any histological differences between the others or genetic differences, or if you have any explanation why was it not responding.
With the biopsy, we did genotyping, and neither on pathology, neither on genotyping, we can have any explanation for the absence of response. So it's very similar to the case which was presented yesterday, which was a very difficult case involving the ENT port, and there is no response to sirolimus, no response to alpelisib, so no explanation for the failure for this case.
Thank you very much.